Welcome back. This is the September 2023 MEC Minute, and our conversation today is going to be about intraosseous access. So, why are we having this conversation? We've been using IOs for years. Well, it's time for an update. So, IOs are frequently placed by us in order to emergently obtain IV access. They're relatively safe, but there can be complications, which is what's prompted this conversation today. We also recently had adverse events secondary to misplaced IO, and this was in a patient in cardiac arrest, and the IO had resulted in a direct complication of the patient's recovery, and that's because the IO was misplaced as part of the cardiac resuscitation. So our case is really about a 56-year-old male, witnessed cardiac arrest. He was provided bystander CPR, and on EMS arrival, he was in VF. On the right, you'll see one of the tracings from the initial monitor setup. He was successfully resuscitated. He had a 12-lead ECG done after resuscitation, and it showed an acute MI. He was transported emergently and underwent successful intervention in the cath lab. After the cath lab, he was sent to the ICU. The IO was still in place. The nurse and the critical care nurse practitioner identified there was swelling. They sent the patient for a CT before removing the IO, and it showed that the needle was through and through, and it went both through the anterior as well as the posterior aspect of the tibia. And if you look at the CT at the bottom right of the slide, the yellow arrow points to the tip of the IO going through the back part of the tibia. They removed the IO. They observed him. They did compartment checks with a special pressure sensing device. And with time, he developed evidence of compartment syndrome, and orthopedics took him to the OR for emergent fasciotomy, meaning they made incisions on the lower leg. They split the muscle bellies and allowed them to decompress, let the swelling go down. The patient then required wound vac, and he ultimately had secondary closure of the wound after the pressures dropped. But he had a good recovery from his cardiac event, but his discharge delayed because of the complication of the IO placement. I think we should also note that during this resuscitation, the crew could not easily find the right size IO needle, so they used the big needle that's typically used for humeral IOs, but used it in the tibia. And unfortunately, the needle allowed them to go too far through the bone and into the soft tissue posterior to the tibial. So we'll move on. Excuse me, quick pop quiz. All these items should be evaluated in terms of true or false. So following are contraindications to IO: fracture proximal to the insertion site, burns distal to the insertion site, cellulitis where you want to put the IO, or patient with generalized sepsis. The second question, and again, all these should be answered from the perspective of true, false. Excuse me, which are potential IO complications? Extravasation of fluid or medications, fracture of the bone, osteomyelitis or infection of the bone, or osteoporosis, which is thinning of the bone. So think about these questions as we make our way through the slides. One of my last slides is going to be my answer to these questions. So when do we use an IO? Well, we use an IO to gain emergency vascular access when peripheral IVs are difficult or impossible to obtain. If you're a child under 12 years of age, an IO can be used for up to 24 hours. If you're 12 and up, it can be used for up to 48 hours. Although honestly, as a practitioner, our goal is to get that needle out as quickly as we can. Insertion sites for adults are proximal humerus as well as the proximal and distal tibia. As part of our protocol, we cover humerus and proximal tibia. You can use the distal tibia overlying the distal tibia at the inner aspect of the ankle or the medial malleolus. In children, we can use the proximal and distal tibia as well as the distal femur. The distal femur has been advocated more and more for children, but it's not yet in the protocol. The one advantage of distal femur is it seems like it's the easiest to secure in the correct position. There's also been discussion about using femoral IOs in adults. Nothing really much officially out there yet, and the Easy IO people say they can't promote that because it's not been FDA approved yet for use in the distal femur of adults. How about complications and contraindications? So we should not place an IO in a bone that has a fracture. So if you have a patient appears to have a tibia fracture, well, that's not a great place to put the IO, because as you infuse fluids, they can leach out through the fracture line into the soft tissue. Really don't want to place an IO in a bone that's had an IO in the previous 24 hours. So if the patient had an IO placed a week ago and you need to use the same bone, you can. You should not place an IO needle through any point of infection. So if you have a patient with what appears to be cellulitis overlying your usual place to start an IO, you should not use it because you have the potential to aggravate the infection or induce sepsis. And then really, as a relative contraindication, if the patient's got a prosthetic joint, I probably would not place an IO. So if the patient has a artificial knee, I don't think I would place a IO in the proximal tibia because that prosthetic joint may have a portion extending down into the tibia where you want to put the IO, and you may end up just hitting a big piece of titanium or metal, and you're not going to get very far. And you could also potentially infect that prosthetic joint, and that's a real mess when those joints get infected. What are potential complications of an IO? Well, there's extravasation, like we discussed with our case. Bone infection can occur. It's not very common, but osteomyelitis can occur as a complication. You can develop a fracture secondary to the needle placement, particularly in somebody with osteoporosis or thinning of the bone. So, it's something you think about. If you need to place the IO in a bone and the bone's available, use it. But just be aware that there's a potential complication. If you have a child with an open growth plate or epiphyseal plate, you can damage that if you put the needle in the wrong spot. And if you damage the growth plate, there may be problems with the child's bone growth. And the other potential complication is pain with infusion. So, if you are awake and alert and you have an IO placed, it can hurt to infuse fluids through that IO, which is why as part of our protocol, we have lidocaine available to provide some anesthesia for the patient. So, anatomically, why do we like to use IOs or intraosseous devices? Well, it all comes down to the fact that the bone marrow and the central portion of the bone is highly vascular, and it has a very large surface area to absorb fluids. So if we infuse fluids into that bone marrow, it will rapidly be picked up into the veins that bridge through the bone to the circulatory system, and it helps move medications quickly and fluids quickly into the body. This is particularly true with humeral IOs, where you can get phenomenal rates of flow through an intraosseous needle. So what do you consider when you talk about site selection? When we talk about the humeral IO up the shoulder, we like to use it because our transit time from the needle to the heart is about 3 seconds. That's very quick. That's almost as fast as if the patient had a central line in place and you were pushing your meds. We can get up to 6.3 liters per hour of fluids through that bone if the fluid's under pressure. There seems to be less pain associated with, say, saline flushes through this area compared to the tibia or the femur, and less medications are required for pain management with the infusion, so you're less likely to have to use lidocaine. If you look at the distal femur, again, for this case, we're talking about children. The insertion success rate is 98 to 100%, which is very good. And then if you look at the tibia, it's a location of convenience. Our flow rate, though, the best we could usually do is about 1 liter per hour under pressure. And I misspoke under the humeral IO. It's 6.3 liters per hour, not per minute. So, we can get good flow rates through the tibia, but much better flow rates through the humerus. What size needle do you use? Well, they all come in 3 sizes. There's the pink, which is 15 millimeter, the blue, which is 25, and the yellow, which is 45 millimeters. We tend to use the pink one for kids that are 3 to 39 kilos, the blue one for bigger kids and adults. The blue one is typically what we use for the tibia, And then we use the big yellow needle for the humeral IO, just simply because the way where we have to place that needle in a patient to get at the humerus. If you talk about sizing and considerations, those black lines on the needles are spaced 5 millimeters, a half a centimeter apart. And EasyIO suggests that when you put the needle in through the skin, when you first make contact with the bone, you should be able to see at least one black line before you start drilling. So, if you have a needle and you think it might be, kind of borderline and it turns out to be short, you don't see a black hash mark on the needle, take it out, put the next size up on the gun or the drill, put it back in through the same hole, and then go ahead and make your placement using the needle. So, think about that as you do it. And if it looks like the needle's too small, don't feel bad about taking it out and putting a new one in. How do we do the procedure? I know for many of you this is redundant and probably boring, but we're going to go through it anyway. So we need to identify a need for an IO. Does the patient really need it? We don't do this for fun. We do it because the patient needs a vascular access between the point of your first contact and arrival at the hospital. So do they really need it? Verify your landmarks. Determine where you're going to put it. You're going to put it in the shoulder. You're going to put it in the tibia. Verify your landmarks. We'll talk about that a little bit. Clean the skin. A lot of times we'll just grab an alcohol wipe, but preferably clean the skin with chlorhexidine. I know some agencies carry chlorhexidine wipes in their trucks, but chlorhexidine is a better skin prep for this than alcohol. If alcohol wipe is all you have, use it. Identify the appropriate size needle, and then place the needle on the drill and drill it into the bone. And then when you're done, take the stylet out. Place the needle stabilizer on the device. I think most of us now carry the EasyIO stabilizer. Place it on the device to hold that needle in place. Put your J-loop on, aspirate, and make sure you get bone marrow. You need to see either bone marrow or fluid to verify placement. If you put it in, you aspirate, you get nothing back, even with a good amount of aspirate pressure. You shouldn't use the device. Same thing if you try to flush it with saline and you get no flow. If you get no flow with the saline, you just can't push hard enough to get it flow through. Stop the procedure, take the device out. And then administer lidocaine if you need it for patient comfort. Don't use the IV or the IO if you're unable to aspirate fluid or bone marrow, if you're unable to flush the line, if the needle wiggles, if it's, when it's correctly placed and in the bone, it should be pretty solid. I mean, if you yank it on enough, it's going to start wiggling, but you should be able to gently tug at it and it should stay in place without any movement. And then continue to monitor this device. Check for soft tissue swelling. Make sure that there is no swelling, and if there is, if you develop swelling with placement, then stop using it and either take it out or leave it alone. But if you're actively administering medications and fluids, you notice soft tissue swelling, the device is dislodged or not correctly placed, stop using it. Either leave it alone and let the ED take it out, or take it out in the field. We'll talk a little bit more about just some of the landmarks for IOs and tibial IOs. I'm sorry, humeral and tibial IOs. And, for humeral IO, this is really something we brought online, probably 2019, 2020. Really what you want to do is you have to find your landmarks, because this is going to be the harder one to place compared to the tibia. So what you want to do is you want to be able to rotate that shoulder, and you have two or three ways to do it. You need to rotate it in such a way that the tibial tubercle, the biggest part of what you want to feel, is readily present with your thumb. So you can either extend the arm straight and then rotate it so that the thumb is facing down, or you can take the patient's forearm and hand and place it on their abdomen. The third thing you can do is similar to putting the hand on the abdomen, except you just put it behind the patient's back. Either way, what you do is rotate that arm so you can find those landmarks. And that's what really it's showing with the hands on the picture on the right. You know, you can take both hands, put them around the shoulder, and your two thumbs should be able to feel where you need to put that needle. You know, once you've got your skin prepped, you've got your landmark set, you need to find that big lump, the most prominent portion of the bone, and place the drill on it. You want to drill at a 45 angle from the horizontal plane. So if the patient's lying flat on his back, you want to take that needle, arc it up about 45 degrees, and then point it toward the opposite hip. If you do that, then when you drill, it should place correctly, which is what the picture on the right is, where the needle is into the portion of the bone, but it's not into the humeral head. If you look at the picture in the middle, that's an incorrectly placed device. It's in the humeral head, and you're not going to get good flow rates. So your optimal positioning is the picture on the right. And if you follow your landmarks, you should be able to get it there correctly. Why would you pick a humeral IO versus a tibial? Well, the humeral site gives you higher volumes, which we talked about before. It gives you better, quicker flow rates to the heart. So if you push a dose of epinephrine, it's there within seconds. And it seems to cause less pain for the patient, and your risk for developing compartment syndrome, like our case example, is much less than if you use the tibial location. Some of the shortcomings, it could be more difficult to secure. The landmarks are not as easily visualized or palpable, particularly if you get a large patient or somebody who bodybuilds. You may not be able to as easily palpate the landmarks through the overlying deltoid muscle. Another potential shortcoming, and I think this is debatable, is whether or not you can get to the humeral site adequately or quickly enough when you're actively compressing the patient, simply because there are other priorities going on. There are some people who think that if you're switching off side to side for your compressors, you should be able to get in there and get the landmarks and get the bone drill. How about the proximal tibia? Well, in adults and kids, we use similar landmarks. On the left-hand side, we're looking for that flat part of your upper tibia. If you feel your knee just below the kneecap, just medial or on the inner side of the tibial spine, you can feel a flat spot. That's where you want to go with your needle. We want to go about 2 finger breadths below the lower tip of the patella or kneecap, and just medial to where your fingers are. That's where you want to put the drill. If you're talking about a young child or neonate, it's not 2 fingers, it's 1 finger. There's still that flat spot. You go down 1 finger below the lower tip of the patella or kneecap, and where your fingertip is, that's kind of your sweet spot to place the needle. If you look at it, what you want to do is find that sweet spot, and that's where you put the needle. 2 fingers for big people, 1 finger for infants below the patella. That's your sweet spot. You don't want to find the sweet spot and go 2 fingers below that. Otherwise, then you'll end up too far down the bone, and the tibia is not as thick in that area, and you're more likely to not place the needle correctly. What are the advantages and disadvantages for a tibial IO? Well, the advantages, you can be used for adults and kids. We typically don't want to use humeral IO in children under 12 to 14 years of age. It may be easier to access for patients in cardiac arrest. Our disadvantages, slower time to circulation, a slower flow rate, more likely to have discomfort with infusions. So, you make a choice. If you need an IO, place it correctly. It's your choice to decide if you're going to use the humeral head or the proximal tibia. At some point, we may transition to the distal femur for children and eventually for adults. I don't think we're there yet. Okay, questions and answers for the pop quiz. Again, all true, false. So which of the items under number 1 are contraindications to IO? So fracture proximal to the insertion site. That's true. If you have a broken bone, you should not be using it for intraosseous placement. Burns distal to the insertion site. That is false. If you have a burn below where you want to place the IO, then you can place an IO in that bone. I think there'd be some controversy over, should you put a needle through the bone if you need access, or should you place it if it's proximal, if the burn is proximal to your insertion site. In that circumstance, or those circumstances, I think I would look at my other locations. But if I had a patient with multi-system burns and every one of my options had a burn over it or near it, I would use it because I have to get access somewhere. How about cellulitis over the IO site? That's an absolute true statement. You should not be using an area that's got cellulitis to place your needle. You don't want to drill through infected skin. So if the leg is cellulitic, find a different site. How about sepsis? Well, that is not a contraindication to IO placement. In fact, it may be one of our biggest indications to get IO access. If we have a septic patient who's hypotensive and trying to crash on us, and we cannot find peripheral access, then we should be using an IO. We need to get our volumes, fluid boluses going, and do what we can to keep that patient alive to get to the hospital. So sepsis is not a contraindication for IO placement. How about what are potential complications? Well, extravasation, I think that's easy as a true based on our clinical scenario. Bone fracture, that is also another complication that's recognized for IO placement. Again, it's more likely to be in a patient who's got osteoporosis or thinning of the bone. How about osteomyelitis? Is that a complication? Potential complication? Yes, it is. Every time we go through the skin, we have the opportunity to introduce germs into other areas where infection may develop. So if you don't prep the skin correctly, or even if you do, there is a chance that when you drill that patient, you're going to be introducing bacteria into the bone that can then result in osteomyelitis or bone infection. But it's a balancing act. Patient needs access, or they're going to suffer bad consequences. Well, we're going to put the needle in. We'll deal with the complications if and when we have to. And then osteoporosis, is that a complication of intraosseous placement? The answer to that is no, it's not. That's a false. Osteoporosis is something that we develop over time as we age. It is not a direct complication of IO placement. Having osteoporosis may make it easier for us to develop a fracture after the IO is placed. Again, if we have a true emergent need for the IO, place the IO, we'll deal with the complications afterwards. So in summary, IOs provide rapid vascular access. That's why we use them. The humeral site is generally the least painful and the quickest to access. All of our EMS medications can be given via an IO, and we can also give blood products via an IO. So if you place an IO on a patient, you put it in their shoulder, they've got major trauma and hemorrhagic hypotension, hemorrhagic shock, we can give them resuscitative fluids as well as blood products through that IO. If you're going to give fluids, they do require a pressure bag, particularly for the tibia. If you place an IO, you should check for the correct placement, and you should recheck frequently. It's something that you should check several times during your transport, and my suggestion is you also check it on arrival at the hospital so that you can verify it's correctly placed. So if there's any problems afterwards, you're in a good position to say, hey, I checked it and it was okay. Again, devices must be monitored and checked frequently once placed, and do not use an IO if it's loose, if the site swells, or fluids cannot be infused. In any of these circumstances, I would stop using the device and leave it alone, let somebody else take it out, or if it's in the way, you can take it out. But I definitely would not use it if you have any of these things present. So that's it. Thank you very much. Thank you for your patience. Hopefully you've learned a thing or two today. Thank you.